Ladies and gentlemen, welcome back to the GIC CIM 2021. We will now get into our fourth session. In this session, we will hear Dr. Rose Freeburn and Dr. Dita, Specialist Anesthesi Consultant Intensive Care, discussing about the current issue in critical care during pandemic era. Moderating this session will be Dr. Arif Mansur, Spesialis Penyakit Dalam, Konsultan Kardiovaskular Intensive Care. Dr. Arif is a teaching staff at the Cardiology Division, Department of Internal Medicine, Faculty of Medicine, Universitas Indonesia, Cipto Mangunkusumo Hospital. Without further ado, Dr. Arif, the floor is yours.
Okay, thank you. Good afternoon, dear colleagues, professor, doctor, fellow student, and all participants. Assalamualaikum warahmatullahi wabarakatuh. Salam sejahtera untuk kita semua. Let me introduce myself. I am Arif Mansur, and today I will be moderated this session. It's been a year since we've been facing COVID-19 pandemic. We have learned a lot how to manage this virus infection. There's so much more to explore and learn. Through experience, basic science, and applicative science, there are so many review analysis and recommendation for COVID-19 management. And today, we will hear some interesting lecture regarding current issue in critical care during pandemic era, including our two topics today about steroid and RDS, acute respiratory distress syndrome. We are very pleased to have distinguished speaker today. We have Dr. Rose Freeburn from New Zealand and Dr. Dita Adityaningsi from Cipto Mangunkusumo Hospital, Faculty of Medicine, Universitas Indonesia, Jakarta, to share their thought and experience with us. Good afternoon, Dr. Freeburn and Dr. Dita.
Thank you.
It's an honor to have you here today. Before we start, let me remind all participants, our audience, to write your question in Q&A or chat. We will answer your question after the presentation. Okay, our first speaker is Dr. Rose Freeburn from New Zealand, who will deliver his lecture about basic principles of steroid in critically ill patients. Dr. Freeburn is consultant intensive care service in Hawke's-based Hospital, Hastings, New Zealand. He is the president of Asian Pacific Association of Critical Care Medicine and also associate dean of Hawke's Bay School of Medicine, University of Otago, New Zealand. I'm sure that we are now really excited to hear our speaker lecture. Without any delay, I would like to invite Dr. Freeburn to deliver his speech. And time is yours, Doc. Please.
Thank you very much, and thank you for the kind introduction. I'll share my screen, which always takes me a few minutes to sort out. But we can find the. So thank you for inviting me to this meeting, and it's great to share with you, even though I'm some distance away. I was asked to talk about steroids in intensive care, and just to clarify, I'm no longer president of the Asia Pacific. I'm immediate past president, but these are my conflicts or declarations of relevant interest, none of which should interfere with what I'm saying today. Now, I was asked to talk about steroids, and this is a very complex and detailed area and full of controversy. And I thought that I'd clarify a few things and go through some physiology and then discuss some of the recommendations and then talk about a couple of new studies that have come out, including one that was released just last night. So sorry, I just need to try to get myself under control here. Cortisol is released as a function of the hypothalamic pituitary and adrenal axis. In health, the hypothalamus releases corticotrophin, releasing hormone, in a diurnal pattern. So it's high in the evening, low in the morning, in the early morning, which is why we feel so terrible when we get out of bed first thing in the morning, especially when we're on call. The ACTH is in turn causes the release of cortisol from the adrenal cortex. Cortisol has a feedback loop, a negative feedback loop on cortisol releasing hormone and ACTH release. In times of stress, this axis is activated. So this is a stress hormone that increases when our body is under stress for whatever reason. One of the things that's important to remember that is prolonged exogenous steroid administration impairs this axis with suppression of endogenous cortisol in patients to be treated with prednisone for a period of time. It's unclear how long that is, but certainly the longer they're treated for, the more it impairs it. In ICU, when we're using it, we do tend to use it for shorter periods of time, but because of the interfered function, it's often important to remember that stopping steroids straight away can cause problems. So the adrenal cortex produces aldosterone from the mineralocorticoid group from the zona glomerulus at about 15%. The cortisol, stress cortisol and androgens are produced at 75% from the zona fasciculata. And the zona reticulatus produces the final little bit, which is really the androgens. The production of these steroids is produced from cholesterol goes to two precursors, then the 17-hydroxide pregnenolone and 17-hydroxide progesterone goes to either producing the sex steroids or down through cortisol and the hydrocortisone. The cortisol and the cortisone. Now, the corticosteroids are 90% bound to a corticosteroid binding globulin and to some extent to albumin. 10% of the cortisol is free, and this is the physiological active part. Its half-life is about 70 to 120 minutes, and this is important when we think to discussing cortisol in critically unwell patients, when the binding globulin may be altered, and to a large extent the albumin is lower. So it's the free cortisol that's important, and the proportion of that may change if the proportion of other binding globulins and albumin change in the serum. Cortisol is not stored in any way, and it binds to intracellular receptors, then moves into the nucleus, changing the transcription of genes. The effects are widespread and occur in many organs. It's metabolically, it stimulates gluconeogenesis, decreases glucose utilization and decreases protein synthesis and increases catabolism, which we see when we give patients steroids, but also occurs naturally. It increases lipolysis and breakdown of fat and oxidation of fatty acids. It increases blood pressure and increases the effect of exogenous and endogenous catecholamines. Usually we think through the upregulation of receptors and increases the effect of angiotensin II through mechanisms that are not that well understood. The other effect that is important is the anti-inflammatory effect. It reduces the circulating lymphocyte count, eosinophils, and decreases the production of cytokines and chemokines in response to standard stimuli. The increased production of the migratory inhibitory factor is also important because it affects the ability of the body to detect and wipe out foreign particles, in particular viruses and bacteria. And as a result of this anti-inflammatory effect, it does actually increase red cell production as well. Now, we talk about steroids and then we talk about the types of steroids, and I think it's important to remember they're not all quite the same. Although, to be fair, in clinical practice, we often interchange hydrocortisone and betamethasone and dexamethasone. In the short term, they don't make much difference. But just remember, it's not their effect on the glucocorticoid, but also their effect on mineralocorticoid potency that's important. Hydrocortisone is equally potent as a minero and glucocorticoid. But some of the others, in particular, prednisone has more glucocorticoid and less mineralocorticoid. This becomes important, I think, when we later in this talk, when we just start discussing the differences between different trials and why some had an effect and some don't. Some, of course, dexamethasone has no mineralocorticoid activity, and fludrocortisone, of course, is mainly a mineralocorticoid. It's important to remember there is a difference between them, although in the short term, the ones we mainly use, prednisone, hydrocortisone, and methylprednisolone, we tend to ignore the mineralocorticoid activity. Now, the next thing to talk about is perhaps a bit of history. Addison described the disease named after himself in 1855 with a patient who suffered from TB destruction of the adrenal gland. Its first use clinically was by Philip Hench, who produced a thing we call compound E, which was sort of an early form of cortisone, which was used to treat rheumatoid arthritis. Before they knew the side effects, they found it was incredibly useful at stopping rheumatoid. It was then used in the 1970s and increasingly in ICU. It was studied and used in ICU and shock. And I can remember many, many years ago being impressed by how powerful these drugs were, particularly in septic shock. In fact, I remember that I thought that they were the answer, but in fact, two studies, but in particular, Bone study in 1987 demonstrated that there was a worse outcome with the use of steroids in septic shock, or what they called bacterial shock in those days, which made us wonder and perhaps halt any discussion and use of steroids in ICU for about 10 years. In the late 90s, there were further studies produced which showed a beneficial effect in lower doses and through selective use. But the use of it remains controversial, and we need to think very carefully before using steroids in any ICU patient. So steroid administration remains controversial. Many postulated benefits of steroids and are there, but the evidence in clinical practice is often lacking. Steroids are potent hormones, and they have diverse physiological effects, which is the problem. It would be nice if we had a steroid that was just anti-inflammatory, or just upregulated the adrenoreceptors, or just reduced swelling, but they don't. They have widespread and adverse consequences. And there's potential for significant impact, both positive and negative, in the critically ill. The thoughtful use of them will result, of course, in more harm than good. Now, I want to cut to the chase so I don't waste your time. After the slide that I'm about to show, you can go home. These are the indications for the use of steroids that are currently accepted in ICU, and this is from a consensus guideline. There are 2 or 3 consensus guidelines, and this is a summary of them, really. In septic shock, the recommendation is 200, sometimes 300 milligrams IV per day, and then with the recommendation that we taper when the vasopressin is no longer required. Now, that's based on a number of studies, all of which have different attributes and failures, but that's what the current recommendation is. Anaphylaxis, without much evidence, but a general practice is that 200 milligrams IV stat at the start of an anaphylactic shock is useful. This has not been studied. In animals, it's been studied, but not so much in humans, but that's thought to be the usual dose. Airway edema, we're trying to shrink the airway swelling as much as possible. So we use methylprednisolone at 40 milligrams IV 4 hours before extubation, and some recommendations say after that as well. The recommendation says there's no point in giving it at the time, it needs to be started beforehand. Asthma, prednisolone or prednisone or hydrocortisone QID slightly higher doses than we use for septic shock for at least 5 days. Remembering the effect of prednisone on asthma is not just as a bronchodilator, but it augments the upregulation of the catecholamine receptors in the airways, and therefore has a really quite rapid effect that is independent of its anti-inflammatory activity. Exacerbation of chronic lung disease, again, using prednisone for 7 to 14 days. It is worth trialing it. Some patients don't respond to this, and once it's been trialed once and they've failed, perhaps we don't need to give it to every person who has COPD. Pneumocystis, obviously, in HIV positive individuals, there's good evidence that using 40 milligrams is useful. Now, bacterial meningitis remains controversial, but the evidence is that in Streptococcus pneumoniae meningitis, dexamethasone QID for 4 days does reduce mortality in some groups. The recommendation is it needs to be given before the antibiotics or at the time of the antibiotics. Once you identify the organism, if it is not Streptococcus, the recommendation is it is stopped if they have Streptococcus to continue it. Raised ICP, I'll talk about more in a minute. Dexamethasone to reduce the swelling around cerebral tumours. And obviously for adrenal crisis and myxedema coma, hydrocortisone is used. There's also some use, but it would depend on the protocol for organ donation. So they're the recommendations, and they've been worked through by geniuses and people on working parties. I think, if you want to go home now and have a cup of coffee, that's fine. I'm going to talk now about some other things. Perhaps the most important part of that is this slide, is when we should not use steroids. Traumatic brain injury, there's been a large trial, the CRASH trial, which finished in 2005. Over 10,000 patients with brain injury were admitted with GCS of less than 14, and the patients were randomized to either get a reasonably high dose prednisolone or placebo. There was actually an increased mortality in those receiving the steroids, and the trial was abandoned before it was completed after an interim analysis. And the recommendation now is we don't use steroids for traumatic brain injury. And Guillain-Barré syndrome, it's also recommended that we don't use it. There's probably no harmful effects, but there's certainly no benefit in the study. There's no significant effect on recovery. It doesn't alter the long-term outcome, and it's feeling it may cause harm. The next category is patients who have sepsis without shock. There are a couple of studies that demonstrate there may be harm from this, and certainly no benefit from sepsis without shock. An analysis of 6 randomized controlled studies in patients with sepsis without shock showed a mortality rate of about 3 or 4% higher than those receiving placebo. And so therefore it's felt that that we shouldn't use steroids without shock. The other group where it's tempting to use steroids, and we perhaps shouldn't, is raised intracranial pressure from either bleeds and intracranial bleeding at whatever level, subdural or extradural intracranial, intracerebral, or from trauma when there's diffuse external injury. The evidence in this group is that there may be harm, and not necessarily from what it does in the brain, but the immunosuppressant effects. Certainly in the trauma group, there's some evidence that the immunosuppression that is induced by the steroids cause problems. The exception, of course, is, as I've talked about before, tumours with edema around them. There may be some benefit in treating that with steroids, and abscesses. Now, there's controversy about this too, because obviously the steroids are immunosuppressive, but it feels there's a consensus that there may be benefit in shrinking the swelling around the abscess to reduce the effects, and when possible, drain them. The other group where harm can be done is in influenza, and it's now recommended not to use those. Now, what happens in the critically ill when the during septic shock? Well, there's a dysfunction of the HPA axis, and this is at all three levels. The cortico releasing hormone, the ACTH, and cortisol are all suppressed. Intracellularly, there's a decrease or abnormal number of receptors, so the effect of cortisol are decreased, and there may be a translocation of the proteins generated by inhibited by cytokines and endotoxins. So there may be a reduced effect of steroids, meaning the patient will require more steroid, and the feedback loops are diminished. ACTH does not kick on as much as it normally would. Now, I talked before about the fact that in the early 80s there were studies done, and this is a demonstration of all the studies that were done. And this is a paper from 2004, about the time we became very interested in sepsis because of interest in activated protein C and other areas. And you can see that overall, in 2004, the overall finding was that there was no beneficial effect or harm from the use of steroids in all the studies that were done. This caused great confusion, and the controversy was, do you use steroids or not? The papers by Bollard and Briegel in the late 90s were the ones that influenced people to think, well, maybe if we use them selectively in patients who are on large dose catecholamines, there may be some benefit. This is an analysis done by Anand's group, looking at systemic review and network meta-analysis of the different types of steroids used in studies in intensive care. And they looked at dexamethasone, hydrocortisone, and other and methylprednisolone, either by bolus or infusion, against placebo and against each other. And the ones on the right, the second one on the right is where there's benefit, and the one on the left is the first item on that scale. And you can see it's quite varied, but placebo seemed to be this is the reversal of shock for interventions, and later when they looked at mortality, you can see although there are some studies demonstrating dexamethasone improves outcome compared to placebo, generally there's a mixed response to the use of steroids generally in critically ill patients. Back in 2018, on the 1st of March, 2 papers were produced that both looked at critically ill patients receiving a moderately long-term use of steroids during their septic shock stage. The first one was by Balavenkatesh and his group, the Adrenal Trial Investigators, which is part of the Australian New Zealand Intensive Care Clinical Trials Group. And their study, despite Balavenkatesh's enthusiasm for steroids and feeling it must have a role in critically ill, and that was the feeling of many of the investigators and many of the other people in Australia and New Zealand, the study failed to demonstrate any meaningful outcome benefit. There was a reduction in ventilated days and in length of ventilation, and it was felt that may be a secondary benefit, but the primary outcome, which was the mortality, there was no benefit from the use of this trial. On the same day, Anand's group and a European group published this analysis of a complex study, but the part that was studied was the use of steroids versus placebo in a much smaller group than Venkatesh's group, which had 3,000 patients, 3,500 patients. This had just 1,200 patients in it. But the French group managed to demonstrate a benefit of hydrocortisone and fludrocortisone over placebo. So I'm just going to stop for a minute. We just had an earthquake. That's where I'm sitting here now. Hopefully it's gone away. Okay, sorry about that. The other benefit that occurred that in Anand's study was there were other secondary, the time to weaning from vasopressors was reduced, the time of weaning from ventilation and the time to reduce the SOFA score, a measure of the being unwell, or it was also reduced. So why is it that two studies done with very similar times in different ICUs in different parts of the world had quite varied results? Well, this is a paper written, to be fair, by Balavankatesh and Jeremy Cohen, who are both investigators in the adrenal study, but looking at what the differences were. And they looked at the differences between the two studies to try to get some understanding of why two studies done on the same group of population had different outcomes. Well, the adrenal study, they were all ventilated and not so many in the European study. The duration of pressure before enrollment was shorter. None of those would sort of make much difference. One of the things that was important was etomidate, which is not widely used in Australia and New Zealand, was an exclusion criteria, while the Anand group used it. And we know that etomidate is an adrenal suppressing, cortisol suppressing agent, even in single doses. And so that was felt to be an exclusion criteria for the adrenal study, but that may have had some effect. The sources of sepsis was slightly different. There was slightly more medical sepsis in the French group. But the thing that perhaps did make a difference was the interventions. And I think we need to think carefully about the interventions. The interventions in the group, the adrenal group, was a bolus, infusion of a steroid, while the French used a bolus. But importantly, hydrocortisone was used in the adrenal group alone, but fludrocortisone was used in the French group. Now, whether this makes a difference or not, we don't know. It's not clear. The other thing that where there was a large difference was perhaps in just general practice, that the proportion of patients receiving vasopressin was higher in the group that in the adrenal group, and much lower. Now, the use of vasopressin in Australia is quite high. Its effect, why it wipes out the beneficial effects of steroids, is not clear. We do know that in retrospective analysis of the VAST study, that if patients didn't receive steroids, they didn't receive benefit from vasopressin. And the data from animals is controversially, some groups seem to benefit and some don't when steroids are added or not added. So we don't understand that may have had a difference between the two groups. Now, I just want to look at the adverse effects of steroids, and finally, hypoglycemia, increased sodium and fluid retention, which could be a significant problem with the edema that already exists in septic shock. The psychiatric side effects, which add to the delirium that patients have when they're in ICU. Post ICU weakness and acquired weakness of ICU could be a significant problem. And of course, immunosuppression, the thing we're most worried about, which was a major problem early on with the use in high dose use in trauma, where patients died, we think, of overwhelming septic shock. All these are problems. The immunosuppression, I don't think we can pass away lightly. Now, to go back to the use when we shouldn't use steroids, is this group here. Now, this is a study, and it's to finally finish. This is a study that came out 2 days ago, and it was by a Greek group, and they studied a small group. There were about 60 patients altogether, patients from 2019 who were not, that didn't have COVID, and a group of COVID patients, a slightly smaller group, 27 patients with COVID. And they looked at a number of things, the expression of the mRNA relative expression in the groups, and the serum cortisol levels in that group. They looked also at the interleukin levels and the interleukin 6 and interleukin 10. And what you can see in this graph, it's is that the ICU COVID group had higher gene expression for cortisol and higher cortisol levels compared to the general group, if anything, lower levels of interleukin-10 and interleukin-6. And that means that using steroids in COVID-19 treatment is perhaps not as straightforward as we think, and there's no evidence from this data that suggests we should be using steroids to augment the treatment of COVID patients. And I say that because it's become very important. This is just, there's no written papers about this. There's our newspaper articles that mucormycosis, the black fungus that's become very prevalent in patients in India, is certainly influenced by steroid use. We need to be cautious we start using steroids in COVID, that we don't cause the problem to be worse. So when should we not use steroids? I'd say all that list, and I'd say in COVID-19 we shouldn't be using steroids routinely, except perhaps in a clinical study to look at it carefully. Are there any questions?
Okay. Thank you, Dr. Ross, for your comprehensive presentation, Doc. I'm sure a lot of questions from the audience, and we will discuss later in the discussion.
Okay, thank you.
Okay. Okay. And now we will have our second lecture from Dr. Dita Adityaningsih, and she will talk about comprehensive intensive care in ARDS, acute respiratory distress syndrome. Dr. Dita is staff in anesthesiology and intensive care department, Cipto Mangunkusumo Hospital, Faculty of Medicine, Universitas Indonesia. She completed her anesthesiology education in 2006, intensivist in 2011, and PhD in 2019. Dr. Dita, time is yours.
Thank you, Dr. Arif. I would like to share my slide first. But before
appropriate one here.
Okay. Thank you, Dr. Arif. Thank you for the GICCIM committee for inviting me today in this symposium this afternoon. And my topic this afternoon is comprehensive intensive care management of ARDS. For introductions, the first publications of ARDS was in Lancet in 1967, presented by the first definition by Osborne, based on 12 patients with severe hypoxemia that was refractory to supplemental oxygen, but was responsive to PEEP. And the autopsy shows the widespread inflammations, edema, and hyaline membranes. And over the next 25 years, several different definitions were proposed with varying diagnostic criteria. And in 1994, broad consensus was achieved with publications of the American European Consensus Conference using the acute lung injury and ARDS definitions based on timing, oxygenations, chest radiograph, and pulmonary artery wedge pressure to exclude cardiac origin pulmonary edema. And this is the latest Berlin definitions of ARDS in 2012 that add corrected minute ventilations as a surrogate measurement of the dead space that correlates with the severity and mortality in ARDS patients. These are the additional parameters, which is P-2, minute volume corrected, lung dynamic compliance, and extravascular lung water index that are associated with the severity of the syndrome, which is mild, moderate, and severe ARDS. The next objective of the comprehensive RDS management in ICU are including sorry. Sorry, Dr. Arif.
Okay, take your time, Dr. Dita.
Yes. I don't know what happened. Hold on. Okay. Hold on. Kenapa nggak bisa ya? Hold on. Sebentar.
Dr. Dita, maybe
Yes. Maybe I cannot share. Okay. Okay, I try to
open your slide again.
open slide again. Yes.
And view.
Okay.
Yeah. Yes, when you click on the left side slideshow. In the
which one?
On the up left side.
Okay.
Upper left side.
Upper left side.
There's
There's
green, red, and slideshow.
Slideshow. Which one? Slideshow.
Which
one, Dr. Arif?
This one.
Hold on.
No.
Hold on. I don't know why I cannot share the. Okay. Why I cannot share
the text recording text after you
share, and then
there is menu in the upper left side.
Upper left side.
Recording. You see the red recording, and there's a slideshow.
Recording. This one? No.
Oh, no.
Yeah. Share again. I cannot share the slide. Can you read my slide?
Okay, we can read.
But I can
continue your presentation. I think it's okay. We can read your slide. We can see. Okay, we can see your slide.
Okay, hold on. Portion of the screen. Hold on. Okay. Hold on, Dr. Arif. I think it's because I'm using the presentation view, yeah.
Yes.
But I cannot continue, I think. Hold on. What happened? Okay. Dr. Arif, maybe I change to another laptop, I think.
Okay.
Kenapa ya? Share.
Di atas itu ada tulisan live slideshow. Mungkin bisa diklik situ tuh.
Yang mana sih ya? Yang mana slideshow ya?
Di atas ini ada, kalau objektif di atas J-nya ke atas itu ada slide objective show. Kecil.
Nggak ada, Rif, gue. Sebentar, Rif. Kenapa ya? Kok gue nggak bisa ini? Bentar. Maybe gue quit dulu kali ya, sebentar ya. Stop video.
Oke, kalau gitu aku pakai untuk ini dulu ya. Pertanyaan buat ini boleh ya?
Ya. Oke.
Okay, we were waiting for Dita, and maybe we have time to answer question for Dr. Rosbrain. Then it's okay if we discuss some question for you, Dr. Ros. Okay. There's several question for you. The first question came from Trian Satrio. He said thank you, and he wants to ask you if there any benefit of early use of steroid in septic case that have to septic shock.
It's hard to know if the patient's progressing to septic shock.
Yeah.
It's hard to decide when you should start using it. I can tell you what I do, but just to get the evidence there were 6 controlled trials of patients with sepsis without shock, where there was this 3% increase. The mortality was just over 30%, and 33% in patients in the group that received steroids. It's not precise evidence. There's a study called the HYPRIS study, which has looked at hydrocortisone. I think they used 200 odd milligrams, about 200 patients in each group. The was development of septic shock when it was used early, and those who received hydrocortisone showed no difference in rates of progression to septic shock within 14 days of those given placebo. So there was no evidence that stopped the progression to shock. But I think it's different. That's a study. I think it's different if you're looking at a patient and they're going down the level of deteriorating really rapidly, then you may say, well, they're going to be in septic shock in a little while. I'll use steroids. So I'll tell you what we do in our unit, and this is just our experience, is that we don't always use it the moment we start the noradrenaline or adrenaline. We wait, but the moment the level goes above about 8, we add steroids. We tend to, when the level, that's 8 mics per minute of noradrenaline. Once it gets to about 12 mics per minute of noradrenaline, we tend to add vasopressin. And at that point, I always add in some hydrocortisone, and we usually use either 100 milligrams 3 times a day or 50 milligrams 4 times a day, depending on which way the wind's blowing. But that's what we use. We don't use fludrocortisone, but we probably could. And I think, having read just through the studies in the last few days, maybe there's an argument we should be using that. So the early use of steroids in sepsis there's no evidence for it, but I think that's a study result. I think if you've got a patient that is rapidly deteriorating from overwhelming shock, and I don't think you need to wait for any set point. You can start as soon as you need it. But using it to prevent shock, I don't think works. So I hope that helps.
Okay, I think it's clear. And thank you, Dr. Ross. Maybe we can continue, Dr. Dita. It's okay?
I think it's okay. Yes.
Okay. Yeah. Please.
Okay. Thank you. Sorry for the trouble. The next objective of the comprehensive RDS management in ICU are including respiratory, pharmacology, and fluid management. The evidence shows that high tidal volume or high driving pressure resulted in lower survival compared to lower tidal volume or lower driving pressure. It is important to keep open the lung and keep the lung open with a lung protective strategy such as a lower tidal volume and optimal PEEP to improve the alveolar recruitment, while the strategy also should produce minimal pressure swing to reduce lung strain and stress. This is the original RDS-NET protocol to guide the clinician in ICU to set up and adjust the ventilator with the oxygenation goal of PaO2 between 55 to 80 or oxygen saturations between 88 to 95% based on lower PEEP with higher oxygen fractions or higher PEEP with lower oxygen fractions, and keep the plateau pressure not more than 30 centimeters of water. COVID-19 pandemic began to open our eyes that if we did not setting the ventilator the right way, the ventilator may not be working as well, or even can be harmful for our RDS patients. Luciani Gattinoni and colleague has proposed the 2 different phenotypes in COVID-19 patients with RDS, with different ventilatory approach between the 2 groups. There is the type 1 or type L with low elastance, low ventilation perfusion ratio, and low alveolar recruitability that need lower PEEP compared to the type 2 or type H with the high elastance, higher ventilation perfusion ratio, and higher alveolar recruitability that need higher PEEP to improve the oxygenations. Well, this is the algorithm to guide us how to manage the RDS patients if the patient is worsening and has indication for endotracheal intubations. It is highly suggested that the patients to be intubated immediately by the expert and using video laryngoscope if possible to prevent failed intubations. However, if the patient is improving with the supplemental oxygen, we can consider to use the high flow nasal canal or non-invasive ventilator if the patient is tolerating with it, and monitor the patient closely with the target of the oxygen saturations between 92 to 96%. If the patient is getting worse within 1 until 2 hours monitoring, we should not delay to intubate the patients. To manage the hypoxemia in RDS patients, we assess the ventilation perfusion mismatch. If low ventilation perfusion mismatch, we can use supplemental oxygen with high flow nasal canal, CPAP or BiPAP with tidal volume around 8 milliliters per kilogram body weight, using PEEP between 8 to 10, perform awake self-proning, and cautiously giving fluid because the pathophysiological cause are the inflammations and lung vasoplegia. If the VQ mismatch is very low, we use low tidal volume between 4 to 6 milliliter per kilogram body weight, using a higher PEEP but less than 16, or using a PRV mode. Perform prone positions and cautiously giving fluid. And some patients even need extracorporeal membrane oxygenations if the RDS is very severe. Due to the macro and micro thrombosis and increasing the dead space caused by septic coagulopathy, we should give anticoagulant through perorally or intravenously or subcutaneously or using inhalation. This is the approach depends on the severity of RDS. The steroid can be given earlier in the onset of the severe syndrome. The prone position can be done within 12 to 16 hours, and giving nitric oxide inhalations or performing extracorporeal membrane oxygenation as the advanced rescue therapy. The role of high flow nasal canal and its utilities has been markedly increased since the pandemic began. And we should use the high flow nasal canal in moderate hypoxemic respiratory failure or after the extubations from the ventilator to prevent the reintubations. It is not suggested to use the high flow nasal canal to postpone the intubations if the patient is indicated for the intubations. Well, this is our patient, a male, 63 years old, with pneumonia caused by COVID-19 with COPD. We gave a steroid earlier of the RDS course for not more than 10 days and using high flow nasal canal post extubations to prevent reintubations and train the patients to do self-proning when using the high flow nasal canal. And this is also our patient's male, 59 years old with pneumonia COVID with hypertension and COPD. The non-invasive ventilation was initiated with close monitoring in the ICU before the patient was finally intubated. We also gave steroid earlier in the RDS course, not more than 10 days, and using high flow nasal canal post extubations to prevent the reintubations. This is a study on COVID-19 patients with moderate or mild RDS using high flow nasal canal, and it shows that the decreased respiratory rate, increasing PaO2 and oxygen fractions ratio in the group of patients who using high flow nasal canal in 2 hours. However, the high flow nasal canal seems to fail to improve oxygenations around 65%, mostly in patients with severe and very severe RDS. And another study shows how the combination of using high flow nasal canal and prone positions resulted in a better oxygenation and outcome in patients with severe non-infectious RDS, this is trauma patients, I believe. This is a study by Guerin and colleague, show that the prone position resulted in a better oxygenations improvement and a higher survival rate in severe RDS patients. The improving oxygenations in prone positions is due to the more homogeneous lung elastance and alveolar recruitment, while it prevents further alveolar over distensions, and also improving the ratio between ventilations and perfusion during the prone positions. As an example, this is our patients with pneumonia COVID-19 with tuberculosis miliar. This patient, we perform prone position for 16 hours and using mode ventilator APRV for 5 days. And it shows the improvement of oxygen saturation from 89% to 99% during the interventions. And this is another patients, a morbidly obese patients with body weight 125 kilograms body weight, which is it's not common in Indonesian patients, I believe, failed on high flow nasal canal initially, and the patient put into prone position on day 2 and show improving oxygen saturations and can be extubated on day 8. When the patient still worsening despite of all the lung recruitment using such as lung protective strategy or prone positions, it is the time to consider to perform extracorporeal membrane oxygenation for those patients, as long as they fit into the inclusion criteria for the ECMO. For IRDS without cardiac problem, the venous ECMO is the choice to perform ECMO in IRDS patients. So this is the example of our patients, a female 32 years old with severe IRDS at cause COVID-19 pneumonia, underwent extracorporeal membrane oxygenator at the 8th day of ICU admissions. The initial saturations was 80% despite of the oxygen fractions are 100%. And we put the patients on ECMO with initially setting cardiac index 2.5 with 2000 RPM, and we can see that the venous saturation entering the venule cannula was 53%, so very low at first, and we set the initial Swiss gas flow at 5.5 with oxygen fractions 100%. Fortunately, the patient slowly improving with the increased saturations into 93 to 100% on the first and the second week, so we could start to win the ECMO on the 3rd week. And on day 19, the ECMO was decannulated, and the patient can be weaned from the ventilator on tracheostomy and discharged from the ICU on day 26, which is, this is the happy phases. During the pandemic, it was suggested to administer the steroid earlier in the course of IRDS. The study by Tong Yo and colleagues shows that hydrocortisone 50 milligrams every 6 hours resulted in better oxygenation and better lung injury score significantly. And hydrocortisone administration also resulted in a better survival in moderate IRDS patients significantly. Another study by Meduri and colleagues show longer administration of steroid also can result in a better survival and shorter ventilator durations. And this study from China shows that early low-dose steroid for 10 days also resulted in a better improvement of oxygenations and lower mortality in COVID-19 severe IRDS patients, especially in those who needed supplemental oxygen or intubated IRDS patients. So how about the fluid management? Murphy and colleague did a very good analysis and concluded that the best survival of IRDS patients were the patient, those who received an adequate initial fluid resuscitation earlier and the conservative or restricted fluid management later on the course of the IRDS. Even the survival also better in patients who receive inadequate initial fluid resuscitation in early course, but still receive the conservative or restricted fluid management later on the course of the IRDS. So this evidence can show us that probably the restricted fluid therapy is beneficial in IRDS patients. Murik and colleague followed the previous study and found that the IRDS patients with lower cumulative fluid balance up to 7 days had a better survival significantly compared to IRDS patients with higher cumulative balance up to 7 days of admissions. So this evidence also show how important to the clinician to manage the fluid therapy cautiously in IRDS patients. The IRDS patients has two different phenotypes, a hyperinflammation and a hypoinflammation subphenotypes that could respond to the therapy differently. The pro and anti-inflammatory mediator can peak sequentially or parallel during the course of ARDS and causes an imbalance immune regulations that cause inflammation and immunoparalysis in the same time at the same patients. That condition can cause systemic inflammatory response syndrome and compensatory anti-inflammatory response syndrome and bacterial or fungal sepsis in that kind of patients. So the management should focus on the balance between anti-inflammatory therapy and antimicrobial therapy, including the adjuvant blood purification, such as continuous renal replacement therapy, hemofiltration, and therapeutic plasma exchange to balance the immunohomeostasis and also control the fluid balance. The study shows that COVID-19 RDS patients who received the CRRT had a better survival compared to the patients who did not receive the CRRT. Failure to respond to the CRRT was in those RDS patients with the older age, higher interleukin 1B, higher interleukin 6, higher troponin T, and higher NT-proBNP, despite of receiving the CRT, which is in those patients show the poor prognosis. Well, this is the example in our another obese RDS patient who failed on non-invasive ventilation initially. The patient was intubated and put into prone position on day 1, and then receiving therapeutic plasma exchange on day 3 and day 5 to overcome the cytokine storm on that day. And this patient can extubated on day 8, and then using the high flow nasal canal post the extubation to prevent their intubations. Another case is a female, 27 years old, with severe preeclampsia, severe IRDS, with lung edema and septic shock due to severe community-acquired pneumonia. After underwent the cesarean section, we performed continuous renal replacement therapy with mode CVVHDF to overcome the acute kidney injury, oligouria, IRDS, and lung edema. The hemodynamic of this patient was unstable with a very high dose of norepinephrine and dobutamine at that time. The initial saturation when we start the CRRT was 89% with the very unstable hemodynamic, and we performed the CRRT for 72 hours. We remove 6 liters of fluid during the CRRT with the result of the negative fluid balance minus 2,500 milliliters on day 5. Yeah. And the saturation and hemodynamic was gradually improving within the day 7, and the patient can be extubated on day 9. So how about the nutrition therapy? Low dose enteral nutrition as hypocaloric or tropic feeding is preferable, with a slowly increase to full dose of enteral nutrition. The high protein is recommended, and there are some research still studying the benefit of probiotic to improve microbiota and anti-inflammatory lipid, such as contained in fish oil, for example. As the summary, these are the original IRDS management from Berlin Consensus of the IRDS in 2012. And this is the new adaptation from the IRDS management with the addition of earlier use of steroid, increasing earlier use of the high flow nasal cannula or non-invasive ventilator in mild to moderate IRDS, low to moderate PEEP, performing the CRRT or another extracorporeal performance. While it's still recommended the low tidal volume ventilations, perform prone positions using higher PEEP, and cautiously using neuromuscular blockage drugs if needed in severe IRDS patients. So as a conclusion, respiratory supportive strategy, monitoring and support of the multiple organ functions the modulating of the immune status and inflammatory responses, and also manage the fluid balance individually are important and beneficial in IRDS management. And the timely and comprehensive management can be a prophylaxis therapy to prevent and treat the complications in guarantee for the recovery of the critically ill RDS patients. Thank you.
Okay, thank you, Dr. Dita, for your presentation. And now we move to discussion. There's several questions. First, I like to read some questions for Dr. Rose. From Dr. Gurmeet Singh. He asked, if we need to use steroid in COVID-19, then which is the best option? The dexamethasone, methylprednisolone, or hydrocortisone? And also maybe you can answer a question from Dr. Heri Kurniawan for severe critical COVID-19. What is the maximal dose steroid can be used? Please, Dr. Ross. Oh, okay. Okay, no problem. Maybe question for you, Dr. Dita, maybe.
Okay.
Dr. Dita, the question is, should we prone patient using high flow nasal cannula? How about benefit of proning in non-COVID-19 patient?
Okay. Thank you, Dr. Arif, for the questions. I think based on the study and based on our experience, we can see the benefit of the prone positions, even if the patient is still awake and using the high flow nasal cannula. Based on the study, we also already perform in our own patients that when the patient is on high flow nasal cannula, we train the patients to do the self-awake proning. If the patient could not comply for the totally prone position, so we can train the patients to sleep on the left and the right side of the body. So it could help a better alveolar recruitment to help the oxygenations. And in terms of the non-COVID patients, it is also beneficial to do the proning when the patient is severe IRDS. We can intubate the patients and then do the prone positions for 16 hours, even up until 24 hours. And after that, we put back the patient into supine positions. We cannot put the patient on prone positioning too long, more than 24 hours, because it could could produce unstable hemodynamic. So it's very beneficial, especially in non-COVID patients with IRDS. So I think it's really highly suggested in many speakers to perform the prone position, as long as we have the person who can perform the prone positioning in our ICU, of course, in our center. Thank you, Dr. Arif.
Okay, thank you, Dr. Dita. The next question for Dr. Rose Freeburn. The question comes from Dr. Gurmeet Singh. The question is, if we need to use steroid in COVID-19, then which is the best option? Dexamethasone, methylprednisolone, or hydrocortisone? And there's another question. What is the maximal dose of steroid can be used? I think that's all.
Okay, so the answer to this question is I don't know, and I live in New Zealand. We don't have COVID. We try not to have COVID, so we've been very fortunate. I don't think we should use steroids in an uncontrolled fashion for when the data suggests it may not need it. I think it's different if the patient has pneumonia as well as COVID, or is getting some extensive therapy, but I certainly don't think we should be using it as a prophylactic treatment for patients who have COVID that are just being ventilated or are not ventilated. I think there are more dangers. Which drug I should use, I don't know. There is probably some evidence that if you're trying to immunosuppress patients, that the longer acting ones are better. And the second question was, sorry.
The maximal dose. If you use, how the maximal dose can
the maximum
be?
dose. So for septic shock, the recommendations, there's 2 studies that were positive early on were 200 milligrams a day and 4 doses, and 300 milligrams. If you go to a higher dose than that, say using 200 milligrams, so 600 milligrams a day, the immunosuppressive effect of steroids increases. So what benefit you get from the catecholamine benefit doesn't get any better, but the immunosuppressive effect occurs, and so you're more likely to get super infections. So I would have thought 300 milligrams, 400 milligrams a day for septic shock as a maximum. I think it's different if you're trying to damp down an inflammatory response, such as an SLE or some of the different doses, larger doses of dexamethasone to reduce swelling. It's different, but in septic shock, no more than 300 or 400 milligrams a day, I would have thought.
Okay, thank you, Dr. Ross. Dr. Dita, do you have a comment about this actual patient with RDS or septic shock with steroid? Mute, Dr. Dita. Unmute, please.
So we give the steroid, especially in patients with severe septic shocks and severe IRDS. We don't give steroids in septic patients without shock, or in IRDS patients, which is not severe. We do not give the steroid in those kind of patients because we're afraid of the immunosuppressive effect from the steroid. But by the time the patient is on the septic shock, refractory septic shock conditions, and then we start using the steroid to help the shock itself, and hopefully it can reduce the vasoactive needs on these patients. So we usually use methylprednisolones and hydrocortisone in those kind of patients, and we usually do not use the steroid more than 10 days.
Okay, thank you, Dr. Dita. The next question. Okay, we have limited time, so I will choose some question. Okay, about to Dr. Dita, about SIRS and immunoparalysis syndrome is very critical issue. Can you explain what clinical or lab parameter we can question that patient is in immunoparalysis phase?
Okay. So patients with systemic inflammatory response syndrome, of course, the symptoms is just like for patients with sepsis, which is high fever, leukocytosis, tachycardia, and shock. Yeah, and the parameter usually show that leukocytosis and very high inflammatory marker. If we can perform the lab such as CRP or interleukin-6 or interleukin-1, we can get a very high of CRP, high interleukin-6 or interleukin-1 in those kind of patients, and also TNF-alpha. But otherwise, in immunoparalysis syndrome, usually the dominant of the mediator is interleukin-10, I believe. Usually the CRP is not that low, is not that high, and sometimes the patients show leukopenia, a very low lymphocyte, and sometimes if we could check the CD4, we can find in those kind of patients with low level of the CD4.
Okay, thank you, Dr. Dita. Well, I think the last question would be the end part of our session today. And before it finishes, I would like to give maybe Dr. Ross Freeburn to give take-home messages for us, for the audience and participant, please.
Well, thank you very much for inviting me, and it's been an interesting discussion. What I realise is that with the evolution of respiratory failure due to COVID, we're going to have to relearn a lot about many things, including our supports. And one of those is I think steroids will have a role in somewhere in the treatment, either in end stage respiratory, in end stage ARDS, or in support for vascular disease. But I don't think we should be using it for prophylactic use in early COVID or in early sepsis. So that's my and thank you for asking me. I hope your meeting is a success. It's very hard to gauge that from this distance, but it's satisfying to see that you have a large number of participants in your meeting.
Okay, thank you, Doctor. And Dr. Dita, please, give take some message for the audience. Unmute, please. Dr. Dita, unmute, please.
Thank you, Dr. Arif, and thank you for the committee to invite me in this symposium, and thank you for Dr. Ross Freeburn for a very interesting topic presentations about the steroid. So I think the comprehensive RDS management are very, very important and beneficial to prevent the complications from the ARDS. It's including the respiratory support, pharmacological support, nutrition support, and food management also. Thank you.
Okay, hope everyone who sees this session will get enough information about how to use steroid wisely in critical ill patient and how to manage acute respiratory distress syndrome comprehensively, especially in COVID patient. We hope this session will improve our daily practice to manage critical ill patient. I would like to give my gratitude to all participants and our speakers, Dr. Ross Freeburn and Dr. Dita, for delivering such a great discussion here. And hopefully our discussion would have much benefit for our daily practice and broaden our knowledge. Thank you very much, Dr. Ross Freeburn and Dr. Dita, for your time to share your knowledge and experience in this session. Hope to see you soon in another occasion or meeting, and thank you for our well-spent afternoon.
Yeah, thank you very much. See you and stay healthy.
Yeah, see you.
Thank you, Dr. Arif, Dr. Freeburn, and Dr. Dita for the fruitful discussion on critical care during pandemic era. Ladies and gentlemen, we'll now be entering the second day e-poster presentation session. Today, there will be 11 e-poster presentation, and this session will be moderated by Dr. Jamalul Azizi, MBB, CHBAO, LRCP, LRCS from Malaysia, and Dr. Eric Daniel Tenda, spesialis penyakit dalam PhD, DIC from Indonesia. to Dr. Azizi and Dr. Eric. The floor is yours.
Well, thank you very much. Assalamualaikum warahmatullahi wabarakatuh. It's a privilege to actually chair this e-poster presentation together with my teacher, Dr. Jamalul Lasisi from Malaysia. Assalamualaikum, Dr. Jamalul. How are you?
Waalaikumsalam, Eric. Very well, alhamdulillah.
Alhamdulillah.
There is an echo background.
Yeah, I can see your background. It's good.
The echo. I can hear my.
Oh, you can. Oh, there's an echo, is it? Oh,
I think it's coming from.
Is it coming from? Is it coming from my end?
From your end.
Okay. Can we fix this? Okay. How is it now? Is it better?
Hello. It's better
Yeah.
now.
Okay. Better. Okay. All right. So
Dr. Eric, I follow your instruction then. Because you are the host.
but you're still my teacher, so I need to follow you first. But again, I think it's also a privilege for me to also introduce Dr. Jamalul Lasisi. So back in 2013, I actually first started my fellowship in interventional pulmonology with Dr. Jamalul back in Sernang Hospital, Malaysia. So Dr. Jamalul currently serves as the president of Malaysia Association of Bronchology and Interventional Pulmonology, who will be the host for the next APCD, and hopefully all the participants who actually joining GICCIM 2021 will also register for the APCB, the upcoming APCB 2021 in October. All right, so without any further ado, the poster competition for today, we will have is it 11 poster, and shall we start? Shall we start with the first one? All right. So the first one, the presentant is Dr. Aditya Pradana with Dr. Henny Ratnawulan with the poster title Case Report Evaluation on Axilla Tuberculosis Lymphadenitis using Polymerase Chain Reactions Method. So Dr. Aditya, time is yours. Before we start, I think we only have 10 minutes per presentation, is that correct? So 10 minutes per presentation. Thank you. On mute. Yes. Dr. Aditya?
Thank you for the opportunity. Good evening, Dr. Eric, Dr. Azizi. In this change
Dr.
begin,
Aditya?
yes.
Sorry to stop you. Can you maximize your presentation, please?
Yes.
You can zoom in. Yeah. Oh, the other one. The other one. The left one. No, the other one. Can't really see. Dr. Jamalul, can you see the e-poster on your screen?
I can see the overall poster, all right. Obviously, the font is quite small.
The font is
Maybe,
quite small, yeah.
yeah, so maybe they can zoom in. You know, I can see the title, all right.
Yeah.
Clearly, but obviously the rest,
Yeah.
cannot read. Maybe you can zoom in.
Can you
By
zoom
the way,
in?
Eric, how do I give the mark? Actually, I don't have a piece of paper, so how do I give marks to
Oh,
each
okay.
poster presentation?
Sure.
I'm not
Thank you
quite
very much, Dr. Jamalul. So I will ask some members from the committee to stand can anyone send the assessment criteria for the e-poster to Dr. Jamalul, please?
Yes. I have received it in Word, but for individual poster, how do I mark actually? Uh,
So I think they will do a presentation for about 10 minutes, and then after that we can ask the presenter based on the assessment criteria.
Yes.
okay.
Thank you
Yeah.
for the opportunity. Good afternoon, Dr. Eric, Dr. Azizi. In this opportunity, we will presenting a podcast report, evaluation on axilla tuberculosis lymphadenitis using polymerase chain reaction method. My name Aditya Pradana, and my mentor is Heni Ratnawulan. We from Department Internal Medicine, Faculty Medicine of Universitas Gadjah Mada. Introduction. Tuberculosis is life-threatening infectious disease with high incidence in the world, especially developing in countries such as Indonesia, caused by Mycobacterium tuberculosis. Most the TB case attack the lung organs. The prevalence of patients suffering from extrapulmonary TB infection shows significant number. The World Health Organization defines extrapulmonary TB as infection in patient with tuberculosis in organ other than lungs, like lymph nodes, pleura, abdomen, urogenital tract, skin, bones, joints, and meninges. The form of extrapulmonary TB tuberculosis is still major public health, difficult to diagnosis. In this uh, epidemiological seen with peripheral tubercular lymphadenitis with peak age range 30 until 40 years old. The ratio female 1.78 and male 1.7. This condition can be supported by examination obtained from suspect infected by polymerase chain reaction examination method. In this case, woman 31 years old come with complaints of dropping fever since 1 month ago, decreased appetite and body weight by approximately 7 kilograms in the last 2 months. Deny choking, complaints of cold sweats at night, and having a history tuberculosis contact. Uh, from the general condition, the vital sign is good. In the physical local examination, uh, found a lump in the right armpit and neck. The characteristic as physical immobile, supple, painful. It's measuring 2.5 centimeters. Uh, the patient did biopsy examination in the lump in the axilla. Tissue histopathology results were obtained after 2 until 3 weeks of examination with impression there were no malignant cells, and the impression of glomerulus lymphadenitis was suitable for tuberculosis, and gene expert of sputum didn't detect the Mycobacterium tuberculosis, but the IGRA test got positive results. The patient was declared to have extrapulmonary TB and start to receive fixed drug of anti-tuberculosis therapy. According to body weight, in the 9 months, in the patient's follow-up evaluation, an expert sputum was carried out, but MTB was not found, and the polymer chain reaction from the examination detected the several days, which indicated extrapulmonary TB infection still occurred. In this case, we consider the possibility of this patient being infected direct inoculation, and therefore the origin primary tuberculosis should be still considered. We think that compliance of the patient who initially have lumps and armpit, right neck may be colonized by tuberculosis mycobacteria. In this case, there was probable primary lesion in the young female patient, and there is no ulcer but enlarged regional lymph nodes. according to the tuberculosis management, we patient receive anti-tuberculosis drug category for 6 months and extend until 9 months. In the one study said that PCR examination of tissue specimen was good alternative for test detecting TB, but sensitive. But in this time for examination, it's shorter than the culture. In conclusion, extrapulmonary tuberculosis is frequent case, but diagnosis is sometimes still difficult to distinguish from the other diagnosis pathological condition because this clinical or compliance experienced by patient are almost not pathognomonic. Untuk tuberculosis histopathological tissue culture examination takes a longer time than PCR and TB examination in diagnosing TB infection. PCR assay can give a result within 2 until 3 days, whereas culture mycobacterial tuberculosis in common culture requires 2 until 6 weeks. Thank you for the opportunity.
Well, thank you very much, Dr. Aditya. I will give the first question to Dr. Jamalul. Dr. Jamalul, please.
Okay, thank you, Dr. Eric. Um, so basically, you are trying to suggest that we should be using PCR method to diagnose TB lymphadenitis instead of the other method, so the culture method, which you say takes a long time. I'm not sure whether this method is routinely done in Indonesia, but certainly not something that we do, in Malaysia routinely. But my question is, could we have just done biopsy of the axillary lymph node, and if say the biopsy shows granuloma, in the right clinical setting, we can just start TB treatment. I mean, histology, I don't know how long it takes in your place, but in my place, it takes about, within, usually we can get the result within 5 days, between, within 1 week, which I think is not too long, So why can't we use, we do biopsy, histology? If it shows granuloma, then it means it is likely to be TB. So I just want to get some response from you. Do you get my question?
Yes, thank you, Dr. Azizi. From this case, the patient examination about PCR and TB because this have time shorter than a culture from biopsy from the lumps in the armpit and the neck because uh, if we culture to find the mycobacterial TB again, it's too long to the time.
Are you going to, start using PCR method in every case of extrapulmonary TB? I mean, like, TB lymphadenitis. You say, you have, lymph node, TB lymphadenitis affecting the vital lymph node, submandibular lymph node, or even intrathoracic lymph node when we perform EBUS. Are you going to propose that we should be using PCR method, rather than histology? It's not something that I do regularly. So sometimes I just rely on the histology, to diagnose, TB. So are you suggesting you're going to do this on routine basis?
For this patient, for PCR and TB, for evaluation, not for the diagnosis in the first time. In the first time, patient has have culture the armpit in the neck to the culture the fine mycobacteria. In the next evaluation after drugs therapy, we will uh, check the PCR MTP in this case.
Okay, Dr. Eric?
All right. Thank you very much, Dr. Jamalul. I have a few questions actually. So, Dr. Aditya, so if I can ask, what actually the reason for you and no, no, I believe this is your supervisor to actually submit this e-poster, or in other words, what's the novelty of your case series, or what we can learn from this?
Yes, for this case report about information that uh, a case about detecting the mycobacteria tuberculosis where the patient have drug tuberculosis after nine 9 months, and then patient with evaluation after several months, we will to check the Mycobacterium tuberculosis still occurred or not in the PCR. This patient still occurred the Mycobacterial tuberculosis infection.
So I believe based on your title, what you're trying to actually say that there is a potential role of polymerase chain reaction in diagnosing extrapulmonary tuberculosis, or in this case, tuberculosis at the axilla region, where it's actually better or reliable to diagnose patient who already receive anti-tuberculosis treatment. Is that what you're trying to say?
Yes, thank you. For this PCR TB method for examination have because tuberculosis resistant rifampicin and this tuberculosis mycobacterial
Okay. So I got your point. So I think this is going to be my last question before I give it back to Dr. Jamalul for further discuss about your poster presentation. So what I understand in this case that the team actually suspect this case is TB resistant, and the question will be whether the team actually suspect that it will be hard or it will be difficult to evaluate axilla tuberculosis post anti-tuberculosis treatment that was given to the patient using a histological examination rather than the PCR test.
thank you for the evaluation from the PCR TB in this case sometimes occur to check because in the TB extrapulmonary TB is uh, usually hard to find to evaluate the extrapulmonary TB. So this
Are you
investigation we will
suggesting?
just take the PCR TB for evaluation.
So you suggest that to evaluate axilla tuberculosis post therapy, it's better to use PCR test as compared to histology collected. All right, Dr. Aditya, I think I'm just gonna leave my question to you, and probably Dr. Jamal, do you have any other questions for the presenter?
Yes, Terry.
Yeah.
Sorry. I have nothing else to comment
All right.
about the poster. Yeah.
All right.
Yeah. I'm just I have put down my marks for the first poster.
Yes. Thank you very much, Dr. Jamalul. Dr. Aditya, first, thank you again. Thank you for sharing your case. And I believe that we can also learn from your case to evaluate extrapulmonary TB. As you know, extrapulmonary TB, especially the axillary tuberculosis, it can occur between 3.8 to 20% of extrapulmonary diseases. So again, to best compare which tests that we should take to evaluate post treatment, that's the question that raised from your case report. So again, thank you very much, Dr. Aditya Pradana and Dr. Annie Retnowulan for sharing your e-poster. Thank you very much.
Thank you.
Shall we proceed for the second presenter? All right. So the second presenter, we have Dr. Sitya Teja Saputra and Dr. Ika Tisnawati with the title Emergency Cesarean Section for Preterm Pregnant Obese Women with Severe COVID-19 Infections. Dr. Cynthia, time is yours.
Is my voice clear enough, doctor?
Yeah. This is nice.
This is
Very.
better. This is better. Yeah.
Yeah.
Okay, thank you for the opportunity. Good afternoon, everyone. Let me introduce myself. My name is Cynthia Teja Saputra. I'm a resident doctor of internal medicine, Gadjah Mada University, Dr. Sarjito Hospital, Yogyakarta. And in this time, I will present to you a case report about emergency cesarean section for preterm pregnant obese women with severe COVID-19 infection. And for introduction, COVID-19, a disease caused by SARS-CoV-2, is still a burden not only in the health sector, but also in the economic, social, and political. The case fatality rate of SARS-CoV-2 infection among pregnant women is 13.6 times higher than non-pregnant ones in Washington state. However, there is only limited data about the recommendation of COVID-19 management during pregnancy, and management of COVID-19 in pregnant women is complicated as they have increased risk of complications for both the mother and the fetus, in part due to physiologic, anatomic, and immunologic changes in pregnancy. And for the case illustration, a 31-year-old Indonesian woman presented with a 7-day history of fever, cough, and sore throat. RT-PCR for SARS-CoV-2 infection was positive on the 4th day of her symptom. Her condition rapidly worsened on the day of hospital admission after 4 days of her self-quarantine. She had close contact with her parents and husband who are all positive for SARS-CoV-2 infections, and currently she is during her 32 week of pregnancy with comorbid of grade 3 obesity. On admission, her oxygen saturation was 88% on room air, and the respiratory rate was 32 breaths per minute, with crackles was found on both lungs. Other physical examination were in the normal range. And patient was treated with severe case of COVID-19
32 weeks of pregnancy without signs of labor, elevated liver enzyme, grade 3 obesity, and then patient was admitted to the ICU isolation. On the day 1, the patient developed coagulopathy and also developed secondary infection, urinalysis, so urinary tract infection by bacterium and fungal. Considering the respiratory distress and rapid coagulopathy in this patient, the choice of pregnancy termination was taken before worsening of the mother and the fetus occurs. And the emergency cesarean section carried out on day 3, born a healthy baby boy. And after that, the standard therapy could be given optimally. And tocilizumab was added afterwards on day 4 and repeated on the day 5. The patient was clinically improving and was discharged from hospital on day 18 with positive PCR swab with CT value around 32 until 33 with reference range positive CT value less than 36. And then day +9 after discharge, patient control without any complaints and without signs of pneumonia. And these are the chest x-rays during the treatment. X-ray was getting worse on the day 4 and day 6, but getting better on the day 16. Chest x-ray on the day +9 after discharge was already normal without sign of pneumonia. And then this one, these are the figure of the dimer value and PEF ratio during the treatment. Patient was developed coagulopathy from the days of admission and getting worse as well as the clinical presentation. We decided to do emergency cesarean section, and after that tocilizumab can be given on the day 4 and repeated on the day 5. And for the discussion, pregnant women will have a unique clinical manifestation due to physiological changes that makes diagnosis so difficult. They can be asymptomatic or maybe give symptoms that overlap with labor symptoms like myalgia and diarrhea. Physiological changes in pregnancy make women more susceptible to respiratory infection and rapid progression to respiratory failure. And treatment of COVID-19 during pregnancy itself is a major problem for physicians due to potential adverse effect for fetus and neonates. Besides, obesity in this case also increased risk and death among patients with COVID-19. Mechanism is unclear, but may be related to lipotoxicity and pro-inflammatory state induced by obesity. And besides, mortality in COVID-19 patients is high among patients with obesity due to large adipose tissue mass with high expression of ACE2 receptors. Obese patients also experience increased intra-abdominal pressure and restrictive chest wall, resulting in decreased forced expiratory volume and forced vital capacity and decreased diaphragmatic contractility. And there is currently no evidence to favor one mode of birth over another. One mode of birth should not be influenced by the presence of COVID-19 unless the woman's respiratory condition demands urgent delivery. In summary, we report the successful management of pregnant obese women with severe COVID-19 who underwent an emergency cesarean section, of course taking into account the availability of the fetus. And termination is carried out not to stop the progression of the disease, but to prevent worse outcome when progression occurs. After termination, we can give the standard treatment regardless of the its safety for the fetus anymore. Thank you, doctors.
All right. Thank you very much, Dr. Cynthia Teja Saputra, for your presentation. First, I will give to Dr. Jamalul for questions. Please.
Okay, thank you again, Dr. Eric. Dr. Cynthia, I think during this COVID pandemic, I'm sure all over the world, there are a lot of pregnant, obese women who will undergo emergency cesarean section. So what are the things that you wanted to highlight in this case report? Actually, what are any take-home messages actually from this case? To me, this is something that is I think, routinely performed all over the world, during this COVID pandemic. So what is unique about this case? I mean, the take-home messages.
Okay, first of all, I will highlight that in this case, there are so many comorbidities. The first is this patient is obese with grade 3, and
What's
then
the BMI, the body mass index?
41.
51, quite obese.
41 with body height of 160 centimeters with body height of 105 kilograms, which is included as grade 3 obesity. This is the this is the first comorbid of this patient. And then the other comorbid is this patient is in pregnancy, which is still preterm pregnancy. And then also this patient with COVID-19 infection, which is from the lab test, we found that there is elevated liver enzyme that also makes coagulopathy more severe in this patient.
All right. So I mean, the take-home messages from this case. Well, I mean, I'm not very clear. What are the take-home lessons from this case?
Okay, maybe the take-home message for from this case is we have to consider it the choice to terminate the pregnancy based on the clinical presentation of patient, and there is no evidence to favor one mode of birth over another, and maybe when maybe it's back to the patient personal clinical presentation.
Thanks. Okay, over to you, Dr. Eric.
All right. Well, thank you very much, Dr. Cynthia. I think in general, first I would like to congratulate you to be brave enough to share your case with us. Second, I think to all presenters, the most important thing when we present a case report or e-poster is what's unique from your case, or what's new from your case. What do you expect people or your listener or the participant will learn from the case that you just presented? So I think that's the question from Dr. Jamalul. What's your take-home message from this case? I think it will be based on your presentation. Did the patient receive the antiviral medications for COVID-19?
Okay, thank you for the question. The antivirus for this patient is remdesivir, Doctor.
The remdesivir was given to the patient.
Yes, Doctor.
This is pre-labor. Or after labor. After C-section or before C-section?
Oh, before C-section.
Before C-sections.
Yes.
So all right. So what we understand when FDA when FDA grants the emergency use of authorizations for remdesivir, if I'm not mistaken, please Dr. Jamalo correct me if I'm wrong, but they did not include a pregnant population in their study. So would you be able to help me understand, is there any current guidelines in your hospital that actually approve to give remdesivir in pregnant patients? Please.
Okay, I will try to answer from the guideline that I read before from Australian AUTGA pregnancy category. Remdesivir is belongs to category B, that suggests no risk to animal fetus, but it depends on the clinician, of course, to decide to use whether to use it or not.
So so I think when we actually adopt clinical guidelines from other countries or from overseas, then it is very important to actually acknowledge and to understand whether the guidelines is actually applicable to your hospital or to the national guidelines in Indonesia. So that's the first one. My second question that actually triggers me, you give the patient the anti-IL-6 after C-section, is that correct?
Yes, doctor.
Okay. So what's the reason of giving uh, this anti-IL-6?
Okay. First of all, cesarean section is already performed, and then from the clinical presentation, patient is the saturation patient is decreased gradually with coagulopathy is still progress. And then we also perform IL-6 in this patient with the result of 250, 252. And
You also
also
check.
there is also another indication of this tocilizumab because this patient has CRP in the value of 100, and also the I'm sorry, LDH in 600 and 600. And also this patient is in the severity of severe COVID-19 also.
Right. In this patient, when you give the tocilizumab, do you consider this is an early introduction of tocilizumab in this patient, or this is actually uh, late? I mean, yeah, late introduction or early introduction of tocilizumab.
Pardon, dokter?
So, 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 so based on your case, you give the patient tocilizumab, correct?
Yes.
So the anti-IL-6 that given to this patient, would you consider this is an early introduction of the anti-IL-6 in COVID-19, or this is a later introduction?
Oh, for the for in this case, this patient is coming to hospital on the second week of her disease. So I think it's not in the early infection, but in the pulmonary phase or maybe hyperinflammatory phase. It's
Okay.
also showed on the clinical presentation of the patient.
My last question, did you exclude any bacterial infections with this patient?
We perform urinalysis in this patient, and we found bacterium and fungal. So we assess this patient as urinary tract infection. But on the evaluation after the cesarean, the urinalysis evaluation on day 7 was within normal limits, and it seems that the secondary infection had already resolved, doctor.
Okay. All right. All right then. Dr. Jamalul, any more question from you?
No. Okay.
All right. Again, thank you very much, Dr. Cynthia Teja Saputra and Dr. Ika Trisnawati for sharing your case. We're hoping that we can learn from this.
Okay, thank
All
you,
right.
doctor.
Thank you. Congratulations.
Thank you so much, doctors.
Cheers. All right. We still have another 20 on the list. No, we still have another 8 on the list. So the third one, I would like to invite Dr. Yunita Aryani and Dr. Bambang Sigit. Dr. Yunita, are you joining? Are you with us?
Yes,
So,
can
all
you
right.
hear me first?
Yeah, I can hear you clearly. So, please, Dr. Yunita Aryani, time is yours.
Yes, thank you for the opportunity. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, everyone. I'm
Dr.
sorry.
Yunita,
Yes.
I think you need to switch off one of your device because it keeps giving a feedback.
Okay, I'm sorry.
Yes, thank you.
Okay. Is my voice is heard clearly?
I think sorry. Apologies. I think you need to switch off one of the device with you, or you can turn off the microphone on the other device.
Sorry. This. I repeat. Thank you for the opportunity.
Dr. Yunita, apologies. Are you joining? Are you using two devices? Dokter pakai dua device nggak?
Yes.
Kalau boleh salah satu saja dok, karena kalau dokter pakai dua-duanya nanti feedback. Boleh ya dok? Terima kasih. Dr. Jamal, apologies. I think we have technical difficulties with Dr. Yunita's connection. Dr. Yunita, are you with us?
All right. What's going on now? You ready?
I think the presenter trying to switch device. I think.
Oh, okay. That happens. Virtual symposium, things like this happen.
Exactly. As much as we love technology, sometimes technology failed us.
Anything can happen.
Anything can happen. Correct. All right, we're still waiting for Dr. Yunita. Are you with us? Hello. Alright, I think kalau Dr. Yunita belum siap, boleh maju yang berikutnya aja ya. Alright, I think Dr. Yunita, we will wait for the connection, for your connections. I think we shall move to the next presenter, Dr. Firda Widasari dan Dr. Bambang Sigit Rianto. Dr. Firda sudah di sini?
Yes, Doctor.
Ready.
Dr. Firda is ready. All right. Okay. Dr. Firda, time is yours. Silakan Dr. Firda untuk share screen.
I'm sorry.
All right.
Can you see my screen?
Yeah, we can see your screen.
Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, Dr. Azizi and Dr. Eric and the other participant. Let me briefly introduce myself. I am Firda Widasari from Gajah Mada University, and I'm delighted to be here on behalf of my team to present about our poster, the case report entitled Pulmonary Tuberculosis with Chronic Pulmonary Aspergillosis. Introduction. Chronic pulmonary aspergillosis is an uncommon pulmonary disease complicating many other respiratory disorders that affect 240,000 people in Europe. The most common form of CPA is chronic cavitary pulmonary aspergillosis, which untreated may progress to chronic fibrosing pulmonary aspergillosis. The other manifestation of CPA include aspergillus nodule and aspergilloma like this patient. All these entities are found in non-immunocompromised patients with prior or current lung disease. Various diseases that cause pulmonary scarring or cavities such as lung cancer, cystic fibrosis, bullous emphysema, tuberculosis, and pulmonary abscess predispose individuals to pulmonary aspergilloma. The management of CPA present multiple challenges. Treatment with oral antifungals is the mainstay, but is often prolonged, resulting in significant side effects, cost, and development of resistance. In our case report, there is an Indonesian man, 51 years old. He presented with cough productive with hemoptysis. The patient also complained with dyspnea since 2 months, and it got worse in 1 month before the admission. The dyspnea came out every time the patient coughed. The patient had no fever at the time, neither chest pain nor night sweats. At presentation, the patient weighed 40 kilogram with body mass index is 15.92 kilogram per meter square. Radiological findings were suggestive for pulmonary tuberculosis. Even however, further testing didn't support this diagnosis. At the time, we test the patient with Gen expert sputum, and the result Gen expert sputum for Mycobacterium tuberculosis and for acid fast bacilli was negative on 2 occasions. On our physical examination, we found bilateral crackles in auscultation at the time. This patient had a post-medical history of pulmonary tuberculosis in 2010 with positive sputum. He completed an 8 months tuberculosis treatment, and he had history of smoking 30 years ago. Sputum culture were performed on first day, and we found that this patient was infected by Enterobacter cloacei and Citrobacter coaceri. Thus, based on those results, he treated with sensitive antibiotic. Like you can see in your screen, the CT tests were performed after 4 days of this patient admission, and the result was pulmonary active tuberculosis with suspect aspergilloma. And after the result of CT test, the patient had undergone needle biopsy with CT guided, and it's sent for culture examination. Before the culture release, we treated this patient with fluconazole and plus standard regimen for tuberculosis, which are rifampicin, isoniazid, ethambutol, and pyrazinamide. Culture from biopsy pulmo determined aspergillosis species was resistant to fluconazole. From theoretically, recommendation drug of choice of aspergillosis was istraconazole or voriconazole, which was available at high cost. So this patient started with one of sensitive drug based on biopsy culture, which is ketoconazole. Like you can see in figure number 1, thorax CT scan is before treatment showed aspergilloma, suspect aspergilloma in the superior segment of the inferior right pulmonary lobe, which is there is monod sign positive. The size of aspergilloma is 2.7 times 2.45 times 2.2 centimeter with 4.1 millimeter thick wall cavity and bilateral active pulmonary tuberculosis. Compare with the previous CT scan before treatment, we evaluated the CT scan 10 days after treatment with fluconazole, before the culture biopsy is released, of course, radiologically showed that the appearance of the pulmonary aspergilloma in the superior segment of the inferior right pulmonary lobe was exactly in the same size with previous one before treatment. And then, like you can see in figure number 3, at his follow-up appointment in polyclinic in February 2021, it is 12 weeks treatment with ketoconazole. The patient clinically had a 7 kilogram weight gain and total resolution, his sign and symptoms, which is at the time is HEMOP2. Compared to the latest CT scan of chest, imaging of the pulmonary mass and the others imaging was persistent in the same site. His ketoconazole was discontinued after 12 weeks of treatment, and we continue observation this patient without treatment of antifungal. But the treatment with antituberculosis is continued for 6 months. After 6 months of observation, we evaluate again CT scan. It is still show a well circumscribed lesion in the superior segment of the inferior right pulmonary lobe, but this patient still in the state asymptomatic. However, even the patient had persistent imaging in size of aspergilloma, there was a huge improvement in his signs and symptoms, which were hemoptysis and dyspnea at the time in the hospital. And he even got better in 2 months and even 6 months after the treatment. The discussion, the diagnosis of chronic pulmonary aspergillosis require a combination of characteristics. First, one or more cavities with or without a fungal ball present or nodule on thoracic imaging. Second is direct evidence of aspergillosis infection, microscopy or culture from biopsy, or an immunological response to aspergillus species, and exclusion of alternative diagnosis, all present for at least 3 months. In the case, this patient is immunocompetent host with prior history of tuberculosis in 2010. Was the primary lung pathology that made him susceptible to aspergilloma. Based on radiographies, a diagnosis of single pulmonary aspergilloma was established. Hemoptysis is relatively common symptom in CPA and simple aspergillomas. It may be mild, like this patient, but in some cases can be significant and of large volume. But we recognize that we couldn't exclude that the symptoms, which is hemoptysis, were caused by tuberculosis reactivation or it caused by the aspergilloma itself. Up until molecular tools were more widely used in clinical laboratory, the ITSA on 2016 had recommended tissue and fluid specimen to be submitted in adequate quantities for simultaneously histopathologic and culture examination. On our patient, we did biopsy culture and plus serum galactomannan test as molecular tools. However, serum galactomannan patient, which is taken by serum, was negative in this patient. For the treatment for aspergillosis, pulmonary aspergillosis, the ITSA recommends foriconazole for pulmonary aspergilloma at a dose 6 mg per kilogram intravenous every 12 hours for 1 day, and 4 mg per kilogram intravenous every 12 hours thereafter. You can choose oral therapy. The dose is 200 until 300 mg every 12 hours. A retrospective cohort study support the evidence that oral posaconazole may be a potential alternative for the treatment pulmonary aspergillosis. In this patient, we treated for the reason of cause. We treated this patient with the one of sensitive drug that from culture biopsy with ketoconazole. Study about treatment aspergillosis with ketoconazole was done in 1987 in a placebo-controlled double-blind study that ketoconazole did decrease aspergillus-specific IgG and improve asthma symptom in 7 allergic bronchopulmonary aspergillosis patient. We couldn't find the study that mimic our patient, but this one of sample of study that use ketoconazole to treat aspergillosis. This patient was given
Dr.
ketoconazole.
Dr. Firda,
Yes, doctor.
um, will you be able to summarize your presentation in 20 seconds, please?
Okay. I'm
Thank you.
sorry, doctor.
That's all right. That's all right.
The interesting fact of why I bring up this case is that patient wasn't treated with the recommendation drugs of choice with in pulmonary aspergillosis, but instead of the patient is treated with one of sensitive drug that patient can be given, which is ketoconazole, and the result is the sign and symptom is total resolution, and the patient had weight gain 7 kilograms. Even the imaging of the patient still show the exactly same size of aspergilloma. The patient, we plan to evaluate the CT scan again on next week on Tuesday. If the patient still asymptomatic, and if the patient if still asymptomatic, but if the CT scan imaging still show aspergilloma with same size, we plan to continue observation this patient without any treatment. But if the patient came with the symptomatic example with hemoptysis with large volume and still show the aspergilloma in CT scan, maybe we plan to consult to cardiothoracic surgery if there is any possibilities this patient can be resected for the aspergilloma. Thank you, doctor.
Right. Thank you very much, Dr. Firda, for your presentation. First, I'll give to Dr. Jamalul for questions. Please, Dr. Jamalul.
Yeah, thanks. Dr. Firda, I mean, this is just a case report, and it is about pulmonary tuberculosis, TB, and chronic pulmonary aspergillosis. Again, PTB obviously is very common, and then chronic aspergillosis is also not uncommon. I mean, again, I would like to know. We see TB and aspergillosis all the time. What are the things that you wanted to highlight about this case report? This common thing, that it's a common thing. PTB and aspergillosis common. What are the lesson from this case report?
Thank you for the question, doctors. Allow me to try to answer the question. The different interesting fact from our case is this patient is not treated with recommendation drug of choice, doctor, which is at the time we already inform consent the patient to buy voriconazole is sensitive drug and recommendation drug for pulmonary aspergillosis, but the patient cannot afford it, and we instead of treat this patient with ketoconazole, it's not drug of choice, but the result is satisfying. The patient had total resolution of his symptoms. So maybe in the future we can have another drug of choice for aspergillosis with low cost instead of use voriconazole.
The patient responded to the treatment.
From the sign out and symptom, doctors, but from the imaging is there is still exactly the same size, doctor.
Meaning respond or no respond? No, patient responded to treatment or didn't respond to treatment? Can you remind me?
Thank you, doctor. I think this patient was respond to our treatment, doctor. Even in objectively, in imaging, there is no response in size, doctor, but the symptoms, hemoptysis is total resolution, doctor.
In terms, there was no reduction in the size of the aspergillosis, is it?
Yes, correct, doctor. The size is remain the same.
How can we be sure that the patient responded to treatment? I mean,
Well,
it's tough to rely on clinical symptoms, I wonder.
actually, we recognize that this patient condition still needs further observation, doctor.
Yeah. What do you, Dr. Eric?
Thank you very much, Dr. Jamalul. I think well, I think this case is interesting because after the treatment, you don't see any changes in terms of the size of the nodules. So I personally I don't quite how to say, I'm not quite certain or to say that probably yes, clinically improved, but again, we need to also examine or to be able to see there is a very size in well in the size of the nodules based on the after the treatment. So I don't think that I have further questions, but so are you? So what's the reason then you're not giving the? So because in aspergillosis there are only three treatment recommendations. First one is itraconazole. Second one is voriconazole, and the last one is posaconazole. So so can you explain to us why you're not using any of this three main drugs for tuberculosis?
Thank you for the question, doctors. First of all, the patient had, we already gave the information about the drug of choice to the patient. The first is voriconazole, the best drug of choice for aspergillosis, but the patient couldn't buy the drug because the expensive cost. So the second drug
Is it not covered by the social insurance, BPJS?
I'm sorry, in our hospital it's not covered, doctor.
It's not covered. Okay.
May I continue, doctor? And the second drug, itraconazole, was is not test for the culture biopsy, so we didn't menawarkan terhadap pasien, and posaconazole is not available on our hospital, doctor.
So I think what we can learn from this case then, first, how to diagnose CPA. Second, how to best treat CPA. And the last one, how to monitor the disease progression after the treatment. Correct? Okay. So the patient still at the hospital now, or it's already discharged?
The patient already discharged after 2 weeks on admission, doctor, and still came to polyclinic per month and still asymptomatic.
All right. Okay. All right, Dr. Firdasari and Dr. Bambang Sigit-Rianto, thank you very much for sharing. Yeah, thank you.
Thank you
Thank you
so
very
much,
much.
Dr.
Thank
Eric
you.
and Dr. Azizi.
Thank you.
Thank you. Dr. Jamalul, I just got information that the previous presenter Dr. Yunita Aryani is joining.
Yeah. Okay, Dr. Yunita.
All right, Dr. Yunita, you're back. You need to on your microphone first.
I'm sorry. Yes.
Oh, matiin salah satunya, dokter. Satu device saja.
It's already one device.
Is it already one device? Atau mungkin ada komputer di sebelahnya yang juga buka acara Jiccim ini mungkin. Ada?
Tes.
Yang komputer yang lain mungkin ada temannya yang lagi buka acara yang sama mungkin, Dok. Kalau misalnya memang lagi buka, mungkin yang salah satunya mikrofonnya boleh dimatikan, sama output audionya juga boleh dimatikan, dokter. Jadi nggak akan bikin feedback.
I'm sorry. I'm so sorry. Still my voice is.
Alright.
Tes.
Alright, okay, Bismillah. This one's better. So yeah. Let's start.
I'm sorry. I'm so sorry for the trouble.
Don't worry.
Because
Please.
glitches happen all the time, like in any virtual setting. It's very hard to avoid, you know.
Dr. Yunita, please start.
Thank you for the opportunity. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, everyone. First, let me introduce myself. My name is Yunita. I'm a resident of internal medicine at Universitas Gajah Mada. Today, my aim to present a case report. Of the great imitator disseminated tuberculosis, dilematic in enforcement of diagnostic. We know that Indonesia is a TB endemic country and ranked third in the world. This is quite a challenge considering that TB manifests in various clinical forms. This makes diagnostic sometimes with difficult. There is a 19 years old woman came to emergency room with complaining of a seizure 4 hours earlier and recovered while in the ER. The patient had previously undergone treatment with a diagnosis of pneumonia and suspicion of malignancy based on the result of CT scan of head and thorax, abdominal ultrasound, thorax X-ray, and tumor marker. Patient also complained of coughing, high fever intermittent, then weight loss of 10 kilograms in the last 6 months, then decrease of appetite and night sweat. She has also not having menstruation of 4 months before. The history of contact with sufferer TB is denied. The patient previously lived in Sorong, West Papua. Based on the physical examination, the patient vital signs were within normal limits, and the body mass index is low at 70.2 kilograms per meter square. Then, from the result of thorax X-ray, which was strengthened by the CT scan, showed bilateral pneumonia, suggesting metastatic pulmonary type pneumonic. And there is also shown that multiple hypodense lesion in the liver and spleen, suggesting metastatic features. From the result of tumor marker, there is a hike of CA 125 and also the other two tumor marker, but both CA 11989 and CA 153. Then however, the result of abdominal ultrasound did not support the result of the tumor marker, which is showed that no abnormalities of pancreas or reproductive organ. Then during the treatment, at hospital, an examination was also carried out, FNFB, fine needle aspiration biopsy at the lung to confirm